This video focuses on the use of minimally invasive techniques for the resection of intradural extramedullary tumors of the spine. As an example, we will review the case of a 55-year-old man with long-standing back pain and a worsening L5 radiculopathy on the left over the past 4 weeks. Physical exam is remarkable for decreased sensation to light touch in the left L5 distribution. MR imaging of the spine reveals a concurrent intradural extramedullary tumor suggestive of a schwannoma, as well as a lumbar disc herniation at L4-L5. Given the patient's presentation, his symptoms were attributed to a combination of both the intradural extramedullary tumor as well as the herniated disc, and a surgical plan was formulated to address both pathologies. This picture demonstrates the standard setup for a minimally invasive approach to the lumbar spine. After receiving general anesthesia and the placement of neuromonitoring leads, the patient is positioned prone on a lordotic frame. The C-arm is used for intraoperative localization. The microscope is available, as is a minimally invasive dural closure kit. In this case, the lumbar discectomy was performed first using standard minimally invasive techniques, with the caveat that a larger 26 mm tubular dilator was used as opposed to an 18 mm tubular dilator, and the incision was made an extra centimeter lateral to the midline in order to facilitate subsequent medialization of the tubular retractor for tumor resection. The lamina is initially exposed, followed by a standard laminectomy and medial facetectomy. The ligamentum flavum is then encountered and removed in a stepwise manner, exposing the underlying dura and shoulder of the nerve root. The nerve root is retracted medially, and a standard lumbar microdiscectomy is performed. With the discectomy complete, the tubular retractor is medialized, allowing for visualization and removal of the undersurface of the spinous process and the contralateral lamina and ligamentum flavum. After obtaining meticulous hemostasis, the dura is opened. A needle holder designed for use with MIS retractors is used. We favor use of a nerve hook to extend the durotomy. During the microsurgical phase of the procedure, surgeons accustomed to utilizing the operative microscope may notice few differences associated with using MIS techniques, since the working areas are similarly small in both approaches. Tumor dissection begins by splitting the arachnoid layers adjacent to the tumor. Dissection is then carried forward by gradually separating the tumor from the other roots of the cauda equina. Once the tumor is exposed, we pull on it gently, partially herniating it out of the dural opening. With the tumor isolated, we can directly stimulate both the afferent and efferent nerve roots associated with the tumor. Although in the case of schwannoma, direct stimulation seldom results in a positive motor response. When a motor response is elicited, this is generally due to stimulation of a traversing nerve root and not the nerve associated with the tumor, thus necessitating further dissection. If there is no motor response, the afferent and efferent portions of the nerve can be cauterized and sectioned. Typically, we prefer to section the afferent fascicle prior to the efferent fascicle to prevent rostral rebounding of the tumor above the dural opening due to tension on the afferent limb. However, in this case, the afferent fascicle did not appear to be under any tension, and it was more difficult to access surgically, so the efferent limb was sectioned first. In most cases of intradural extramedullary schwannomas, the tumor can be removed en bloc without the need for additional internal tumor debulking. Dural closure takes place in a fashion very similar to open techniques, but with adapted minimally invasive instruments. In this case, we use a running 6-0 Gore-Tex suture. A watertight closure is generally achieved and can then be inspected, and additional sutures placed if needed. The tubular retractor can then be removed using bipolar cautery to achieve hemostasis as the retractor is pulled out. 0-vicryl sutures are used to close the fascia, and 2-0-vicryl sutures for the subcutaneous layer.